So the next part, I'm going to go through just some physiological motion. Sometimes I'll do this just depending on the motion and everything like that, what I kind of want to gain or what I think this should, or just even confirming some things from time to time. And I'll show one that I use that we actually didn't cover in lab much that I actually like because I can turn into a treatment pretty quick. But what I do is go ahead and scoot towards me a little bit. So, of course, the same motions that we all tested. If I have an idea of where I want to feel that motion at, what I can come down, and usually I use the iliac crest as my kind of guideline and just drop down. And then right there, that spinous process, I'm going to call it L4. Do I know I'm on L4? No, but that can give me a good guidance from here on out that I can keep going back to that spot. So what I'm going to do is I'm going to first go up and I'm going to go down to L5 and I want to work from bottom up. So I'm working on kind of 5-1 and right now I'm going into flexion. And all I can do is just kind of go up, feel that motion, we got it. Go up, see that motion coming into my hand again, perfect, we got it. Coming up to motion into the hand, perfect, we got it. Coming up to motion, boom, we got it. And then just keep kind of climbing my way up the ladder, feeling each motion in between. For extension, I'll be honest, it's way too rough on my body to do both legs. So what I'll do oftentimes is just use one leg. So you'll still get that motion in there. So I can go back, boom, got it. Go back, moves on to there. Go back, moves on to there. So even though this is a little bit far away from my body, I still can control it all the way back just with single leg. This can be done actually from a rotational standpoint as well. Sorry, just making sure we aren't hearing a baby. Rotational can be done as well. Oftentimes, this is more done from the top down. So go ahead and take your arm and rest it here. So then I'll count my way up from 5, 4, 3, 1. And all I can do is just kind of come in here. And I don't have to be as specific like going down. Or I can if I need to have the patient more comfortable. If I can chalk down, boom, go to there. Go to there, and then right there, which actually feels a little stiff going into the rotation. Finally, the one that I'll often assess, because sometimes this can be pretty painful for patients, even though it's kind of interesting because it's not a normal, we don't have a lot of side bend into the lumbar spine, really just a few degrees at each side. It can be really good at assessing because you can also treat it. So basically, I can come up and I get it to where the legs, relax your legs for me. Relax, good. So I've got the legs kind of pinned up just like this against me. And then what I can do is go from top down effect. So I want to make sure, go into that flexion, make sure I haven't blown past everything. And then drop the legs down, boom, and I should feel that bottom spinous process drop into the ground. Perfect. Go down, and then go down, and then just kind of work going down, feeling that motion. From a treatment standpoint, what I can always do is just block that top segment and then actually just kind of work on this. And this is actually, their legs are mainly supported, so it's pretty easy on my body to do that. And that's pretty much it for passive motion. Go ahead and lay on your stomach for me. So next what we'll do is passive accessory. With this one as well, what I used to do was UPAs on both sides going up, and I've actually changed a little bit more to central. Just because I've gotten more and more, I've tried to feel that motion, but we know that we're not really, research says we're probably not the best at detecting that stiffness, but I do know that I can possibly reproduce that pain. So usually, especially if it's screen, I'll do more of a CPA, but if I want to get more localized, I'll go UPA off to the side. So again, get my bearings a little bit, go out, and then use the little cusp of my pisiform there. Go on to L4, drop down to a little bit to L5. And of course with this one, you might want to play with the angle a little bit, assessing, because if you go straight down it might feel stiff. Or if they're already in a lordotic, of course it does. So you might want to play around with going a little bit more at an inferior angle than straight P to A. And then assessing, kind of working ourselves up. So L4. Going L3, preferably the bed would be a little bit lower from where I'm at. we go. Realize you can't see me where that. And then working my way up. And that is our passive accessory motions, kind of working our way up to there. I don't get even more fine in tune than that. I'm really looking for reproductions of symptoms. And what I'll do is I'll make sure if I want to clear that out, I'm hitting R2 to make sure I'm good on that front. The next thing I'll cover a little bit is localization. This is often done through, I do a lot of the localization or 2-point discrimination for patients that are a little bit just too hot to touch. The ones that we can't really get in there and do anything, but we know that we can hopefully kind of crisp up that picture, that kind of blurry picture in their brain from the somatosensory cortex, and localization will do that. So oftentimes what I can do is in the picture is available if you read through the paper that's performed by Lowe 2015, I believe it was the year of that article, and showed, and they use actually 9 different quadrants for the back, and they had the patient have it as well. And what they did was they would basically hit one of those quadrants and ask the patient to state back to them what they hit. And if the patient got it wrong, they would guide the patient to the right answer, and they would do this for 5 minutes. And what they found was the patient that did this immediate increase in their lumbar flexion with nothing other than that localization. So what I'll often do is I'll have the picture and I'll show them, this is 1, spinous process will be, your 2, go off to the side, that's 3. Of course you want to do it on bare skin, tell them this is 4, this is 5, this is 6, all the way down, and then work for it for about 5 minutes. Second one, and I have to fully apologize for this, I don't have any of my tools with me, but the second one I do is 2 paper clips for 2-point discrimination. And generally into this area, your normal can be about 55.5 millimeters is your normal with a standard deviation of 12. So anything beyond that you can see is kind of pathological. But that could do it over here. But again, what I want to do is I want that to be fine points so I can kind of use that localization into those areas to do that. I'll be honest, I never do any type of tactile discrimination into this area. You could possibly do a sharp dull, etc., but I've never actually done it just because this can be a pretty sensitive area for people, but that could be beneficial. And also graphesthesia, sorry, I can't say the word. That actually could be pretty beneficial too for those 2 hot and to handle patients. What you can always do is start with letters, and pretty much what I wanted to do is have about an 80% accuracy with those patients. That can be pretty beneficial. So that's generally what I'll do is testament wise in that order. For those patients that are too hot to handle, and you can have pretty good results with those. I have a patient currently right now for whiplash that's I'm using it for the neck. That's I can't touch her because it spasms when I do, but when I do that, it calms it down, and she's actually getting better and better every week. The one that I'll show you in this position before we flip over is actually a part of the SIJ assessment that we'll go into next, but it's the sacral thrust. And the sacral thrust is simply getting over into the sacrum and pressing down just like this to thrust. And all you're looking for is, does that reproduce your pain? The second thing you can actually do assessment-wise is get out into the long dorsal sacral ligament, palpate into there. That is a really good assessment tool for SIJ. And the sacrotuberous ligament that goes from the sacrum to the tuberosity, fibers will go into this way, so I want to go against that fiber and then find it into there. That can actually be pretty sensitive on someone who has SIJ issues. Mostly what I'm also looking is for the Fortin fingers test, where right there at that PSIS should be within 2 centimeters, that kind of that main pain. Even though the pain referral can go out, I should expect it there. The one thing I should not expect and will not have with an SIJ is your sacroiliac joint cannot refer into the lumbar spine. That was a study by O'Sullivan in 2007 came out, and I think they're quoted 8 different authors that pointed to the fact that the SIJ cannot refer into the lumbar spine. Can you have 2 issues going on at the same time? Absolutely, but if I'm having lumbar pain and that pain, SIJ actually goes a little bit less on my list.